Hello, so this is Diabetic Ketoacidosis by Zainab, Michelle Skeens, Randy, and Michelle Watts. So what is diabetic ketoacidosis? Diabetic ketoacidosis is a serious and life-threatening complication of diabetes, which occurs when the body begins to break down fat to use as energy as a result of the cells not being able to use glucose as energy. Typically, in response to high blood glucose levels, the body secretes a sufficient amount of insulin, a hormone from the pancreas, which signals liver cells, muscle cells, and fat cells to take in glucose to use as energy. As the body breaks down fat, the liver processes this fat in order for the cells to use its byproduct, ketones, as fuel. So who gets it and why? Diabetic ketoacidosis is typically seen in patients with type 1 diabetes because the beta cells in the pancreas create little or no insulin, which makes the body unable to maintain blood glucose levels. However, it can also occur in patients with type 2 diabetes. Diabetic ketoacidosis can be prevented and treated by nurses providing patients with the needed education on its causes, prevention, symptoms, diagnosis, and treatment, along with knowledge of delegating appropriate tasks. So, what causes diabetic ketoacidosis? Diabetic ketoacidosis can result from a combination of many different factors. If the pancreas is not secreting enough insulin, the body will be unable to use glucose as fuel. Environmental factors which cause stress, such as being in war, physiological factors such as infections, or emotional stressors such as surgery can all lead to decreased insulin production within the body. An inadequate dose of insulin, one being too low, can also cause the development of DKA. Increased glucose production in the liver and kidneys, as well as inadequate insulin secretion doses or decreased glucose use in the peripheral tissues, will also contribute to the development of DKA. A combination of these factors causes the body to break down fat as ketones to be used as fuel, which ultimately creates the blood within the body to become acidic, known as ketoacidosis. Signs and symptoms of DKA may result quickly, and diagnosis is imperative. Therefore, educating the patient on what to look for and how to look for it is important.
Manifestations of diabetic ketoacidosis: Kussmaul respirations, flushing of the skin, dry skin, dehydration, weight loss, mental status changes, lethargy, coma, nausea and vomiting, fruity odor on the breath, and increased thirst, urination, and hunger. Let's talk about Kussmaul's. Diabetic ketoacidosis will cause the body to go into a state of metabolic acidosis. In order to try to correct this state, the body's compensatory mechanisms will kick in. Kussmaul respirations are the body's respiratory compensatory mechanism, which activates in order to try to breathe off the excess acid in the body and return to homeostasis. What does Kussmaul's look like on a strip? On a Kussmaul strip, the waves are more peaked and closer together, indicating an increased rate and depth of respirations. What do the labs look like? There's a blood glucose greater than 300 milligrams per deciliter, a pH less than 7.35, a bicarbonate level less than 15 milliequivalents per liter, serum ketones present in the blood, ketones present in the urine, an increased BUN greater than 30 milligrams per deciliter, an increased creatinine greater than 1.5 milligrams per deciliter, a low, normal, or high serum sodium, and an anion gap greater than 10 to 12 milliequivalents per liter.
So how do we treat DKA? First, we want to assess their airway breathing, circulation, level of consciousness, hydration status, and electrolytes. In treating DKA, we will correct the fluid and electrolyte imbalances using also insulin therapy, fluid replacement, and lastly, we also want to monitor their vital signs continuously during this therapy. So let's talk about insulin therapy. The goal of insulin therapy is to decrease the blood glucose by 50 to 75 milligrams per deciliter per hour. And by doing so, we are going to start with a 0.1 unit per kilogram bolus. After doing so, we will then start a drip rate at a rate of 0.1 units per kilogram per hour. Next, we're going to talk about fluid replacement therapy. So the priority outcome is to restore vascular fluid volume. And in doing so, we will infuse 0.9% sodium chloride bolus at 15 to 20 milliliters per kilogram per hour. Then we are going to infuse at 4 to 14 milliliters per kilogram per hour. When we reach a blood glucose of 250, we will then change it to 5% dextrose and 0.45% saline to prevent low blood sugar and cerebral edema, which can be complications. So when is DKA resolved? Well, DKA will be resolved when treatment measures will be the blood glucose at less than 200 milligrams per deciliter. The anion gap is 12 milliequivalents per liter or less. The bicarbonate is greater than 18, and we want the pH to be greater than 7.3. Next, we will talk about what a nurse can do to delegate tasks. So a certified nursing assistant, also known as a CNA, can assist with activities of daily living, which is also known as ADLs, such as getting the patient dressed or bathing them. They can also measure their height and weight, measure the intake and output. They can also sit with the patient for safety or for comfort measures, and they can take vital signs. So lastly, we're going to talk about the delegation of a vocational nurse. So the vocational nurse, or LVN, licensed vocational nurse, can perform all the tasks and duties of a CNA, as well as administer medications, obtain a history and physical, provide education, and they can also oversee and delegate a CNA. Next, we're going to talk about DKA prevention. So what we're going to do is we're going to educate the patient on how to check glucose levels every 4 to 6 hours. The doctor may need to adjust the insulin dose as needed. We also want to maintain hydration with 2 liters of fluid per day. And in doing so, the patient should not intake any sugary or caffeinated beverages. So DKA prevention continued. To ensure levels do not exceed 250 milligrams per deciliter, frequent blood glucose checks may be needed if the patient becomes ill, experiences nausea, vomiting, or anorexia. We also want to educate the patient on notifying the doctor if any of the following issues occur, such as persistent nausea, persistent vomiting, an inability to tolerate foods or fluids, a temperature greater than 100.5 degrees Fahrenheit, and an elevated glucose levels unrelieved by 2 consecutive insulin doses.
And now we have some NCLEX style questions for you. Question number 1. The diabetic ketoacidosis patient will present with all of the following signs and symptoms except select all that apply. And the answer is A and D, an increase in pH and a decrease in urine output. The rationale is the DKA patient will have a decrease in pH, not an increase, and there will be an increase in urine output. Glucose is not used as an energy source because of the insulin deficiency related to DKA. Instead, fat is used and ketones are present, which are the byproducts of fat metabolism. This buildup is the reason why the patient experiences a metabolic ketoacidosis. The patient also presents with Kussmaul's respirations, which is the compensatory mechanism by the body. The patient also experiences hyperglycemia, which is seen in elevated blood glucose levels. Question number 2. The nurse recognizes that the newly diagnosed type 1 diabetes mellitus patient needs additional teaching on preventative measures of DKA when making which of the following statements? Select all that apply. The answers are A, B, and C. I will stop taking my insulin if I am too sick to eat. I will decrease my insulin dose during times of illness. I will adjust my insulin dose according to the level of glucose in my urine. And the rationale for these answers are: the patient should continue to take insulin even if too sick to eat. The patient should not change the insulin dose during times of illness or according to the level of glucose in the urine. The healthcare provider can change the dose of insulin if needed, and it is usually adjusted according to blood glucose levels, not urinary glucose readings. Question number 3. The patient admitted with a diagnosis of DKA has an initial blood glucose level of 950 milligrams per deciliter. The serum glucose was decreased to 240 milligrams per deciliter after a continuous IV infusion of short-acting insulin was started along with IV rehydration of normal saline. What would the nurse prepare to administer? And the answer is C, IV fluids containing dextrose. The rationale for this is the DKA management focuses on fluid and electrolyte imbalances as well as bringing the serum glucose levels back to normal values. Correcting these imbalances too quickly can cause complications such as hypoglycemia and cerebral edema. MPH and phenytoin are not used for treatment of DKA. Hypoglycemia is treated with 50% dextrose. And that is our presentation, and thank you for listening.